I did teach like musculoskeletal and ortho, so we did talk about the spinal levels as far as peripheral nervous system. But I put together this little chart just to help students not lose points on something they know just because they got nervous because they see a spinal level and all of a sudden their brain turns to mush and they're like, tricep, right? You know, and so you're not sure. So this is a very unorthodox chart because I have smashed peripheral and central nervous system together, which is not really a thing. Okay, like C6 for central is very different than C6 for peripheral, but I'm a simple mind. So this was just how I would have organized my studying. To me, the nervous system is like a roadmap, and now that we all have GPS and navigation systems, we're much more familiar with that. And so I just wanted you to walk away with a sense of what lives near C5, like what could go there, what couldn't, okay? And so that you could at least by process of reading the question have a really good chance at knowing a spinal level question. Now, if we're talking about spinal cord injury, we're talking about a whole different conversation than if we're talking about I have a herniated lumbar disc at L2 and what muscles might be weak, or something peripheral. But overall, I wanted to give you some way to make sense of what could seemingly be contradictory information in your score builders book, okay? If you were to look up, oh, I need to know what's going on at C4, there's 15 different pages where C4 shows up. And it's giving you little bits of information, all different pages. So the first goal is for you to be able to identify all that information in one place. So that's what this grid is, just to go, let's take everything it's giving me, and let me at least just get in one place so I can sort through it. So the reason for the sticky notes, and you may end up needing to tear those in half so you can stick them all over the place, as you can see I've done over the years, is to find all the places that give you a spine chart or a reflex chart or a myotome or a dermatome chart or functional levels based on certain spinal cord injuries, or what's the muscle test to determine the integrity of C5, okay? So in your version, do you all have the blue aqua one? So once we find some page numbers, we'll be able to put those page numbers on the board and it'll be good for everybody. So what I'd like you to do is look up either in the index or start flipping through like the orthopedic section and call out all the pages that have, like, what's this page? 226. Look at 226. That gives you nerve root, dermatome, myotome, reflexes. We're going to identify all the different pages and try to condense that study material onto a form. So what 226 is one. I'll just put them up in here. And you're going to put a little sticky on there because we're going to go through some things and we're going to have to flip around. So 226 is one you can put a sticky on. And
272 is the functional outcomes for complete lesions.
Okay, mark that one so you can flip back and forth. You got stickies you want to mark?
Yeah, but I don't have this. I have it. Yeah. What are we looking for?
Are you just borrowing this one?
Yes.
Okay.
What are we looking for? I'm sorry.
You have this one?
Mm-hmm.
Well, then look for the numbers in mine because they're probably, yeah, it's probably these ones.
What are we looking for?
Anything that gives you information about this chart where your spinal levels are listed, whether it's which reflex is tested at that level or what are the muscle like tests to see if it's, yeah. Because there's several pages that give you similar information. It's like you can't really keep flipping back and forth. Yeah, what's that one?
73.
Page 73 is a humdinger. Humdinger.
24 gives terminology. Or 275, sorry. I don't know when I was going.
And what's, yeah, 274.
There is one, and then
I'm trying to simplify.
oh, 73.
73. Yep, we got that one.
Oh, sorry, I thought it was 273.
213. 231. Thanks.
Yeah. But see, you've got your downtown reflexes. So this is gonna be part of that.
Page 1 and 2
222.
and 23. That's
I have a
my
different
old
book.
book.
Yeah, this is mine.
Oh, that's the old book?
Yeah.
Okay.
No bueno.
No bueno.
I don't like old books.
So you guys might have the same book.
Yeah. No, I have this one. Which is
She has.
Yep, that's-
She has the same one.
236 sensory testing.
Yep, perfect.
I think like 231 or 236.
Oh.
Every page in between us.
So when you're trying to study your spinal levels, it would be very frustrating to try to have to be flipping through all these to try to make sense of it. So we're just going to try to at least get this information on one chart in an oversimplified manner. So does that cover most of them? You think anybody else finding anything else that would list anything? And this should probably be good. Everybody have those marked in your book now? Everybody has all those marked so I can erase?
Oh wait, no, I think I'm missing 2.
226, 272, 274, 73, 231, and 236 as a start. There's probably more.
There's pages before and after all this.
Yeah, in between. But it'll give you a place to flip to.
The last one, 236. Okay,
All right, everybody have these pages marked? Okay, I'm going to erase these. Okay, so here's what we're going to do. When you get a question, if you were trying to test a person's ability to differentiate spinal levels, what kind of question would you write?
An easy one.
Because you are a kind person.
Yes.
But let's say you're not. Let's say you get a jolt out of torturing people. Okay, so what kind of question do you think they will write for you?
It's a spinal cord injury at like level C7. What functions do they have?
What do they have? What kind of equipment do they need on their wheelchair? What kind of transfers? Will they, what are the, yeah, good. What if it's a peripheral spinal nerve question? Might a question be that was peripheral, not central? Ooh.
Patient demonstrates hypertone.
No, that's central. So peripheral would be, I have a herniated disc at C6. Which finger goes numb on me when I sit flexed all day? It's my thumb. I can tell you that from, I woke up with my thumb was numb, right? Yeah. And so, like I said, we're smashing central and peripheral together. So just forgive me in advance. All right. So here's what we're going to do. They're going to ask you, we hope, questions that matter, that are going to be the most high volume of what you're going to see out in the clinic, right? Not some random T11. Yeah, okay, so of the cervical spine, of these options, which one should you know? The street, the side streets, the backyards, and the front yards? C6, C7?
That's C6.
Oh, I think
But why is C7 important? What do they have at C7?
Extension.
Triceps extension. Yes. So now they don't have to do what? They're sitting. What are they? Yeah, it's easier for them to do pressure relief.
They still have to do it though, because
Transfers are easier. How about just plain old sitting? Is sitting going to be easier?
Yeah.
They can do that.
yeah. So what happens when you get between C4, C5, and C6? How jumbled is that? Right? So you're like, what if they ask you a C5 question? You're like, oh crap, C5. Okay? So here's the reason for this. We are going to use just the most key ones. So we're going to do 5, 6, and 7 right now. And we're going to do it in a way that it's logical and intuitive. So like, okay, you could fake it till you make it. Like if you can at least know who lives at 6, you're going to know who lives on the street before him and the street after him, because it has to logically go there. Okay? We'll do the same thing for some key lumbar ones. Okay? And we'll look at the thoracic spine a little different. Then when you go home, you get to fill in all the rest. Okay? But we're going to really know this because no one's going to trick you. If I say C6, you're going to know whether bicep lives there or not. Or like, oh no, like what's there? Okay. You do not have to have the brachial plexus memorized, thank God, to get through this, but it wouldn't hurt to look it over a little bit. Okay, so let's start at C6, just because it's sort of like, it's definitely a bridge between some major changes in function, right? And I will invite Lisa to jump in at any moment. All right, so when you're looking at C6, look at your tagged pages. Find the ones that talk about, first of all, the reflex. What reflex can you test at C6? What do you got, Raul? 226 has it? What reflex for C6?
Bicep, brachioradialis.
Bicep and brachioradialis for the reflex. Now, of those two, which one lives farther down the street of C6 anatomically? You got bicep, brachioradialis. In my mind, I put bicep at the top of this box. That's just how okay? So for the reflex, you have the bicep reflex and you have the brachioradialis reflex. Okay, let's compare that to the C5 reflex. Are there any similarities? Can you also test the integrity of C5 through a reflex? Is there any listed?
Same ones.
Same ones, okay. So C5 and C6 have some redundancy, and as was brought up before, when you have to differentiate between the two, you have to be given information in the question that rules out the other one of something that only lives in the other one. They cannot expect you to differentiate C5 or C6 and just say, well, the reflex is the bicep and the brachioradialis, because that doesn't give you enough information. So as we do this, we're also going to go, oh, like what was the word you called it? The marker or the indicator or something? What was the word you guys used to say this was the definer in the question that separated it from something else? There was a word you used. But it was a good word. It was a cool word. Okay. Well, you were only smart 2 hours ago. It's gone. What are the reflexes for C7? Any others? Okay. Are there any reflexes for C8? Anything for C4? Okay. So there you go. You've got reflexes figured out for the upper extremity. Basically. Now let's stay with C6 for a minute. The difference between muscles tested, or myotome, it's similar but different. But if you're doing an orthopedic screen on someone, what quick manual muscle test? We're not talking about a complete spinal cord injury muscle test. We're talking about a quick muscle test to check C6, a muscle that has main innervation by C6. What myotome is listed or muscle tested? Okay. Okay, so I'm going to put bicep up to the top, supinator, and the middle one was wrist extensors. Mm-hmm. So we got bicep, supinator, wrist extensors. Okay. What about C5? The bicep, now I'm going to put down here because the others are above it. Tell me the other ones again. Supraspinatus. And infra. Your radiator. Your rotary cup.
Your rotary cup is the usual thing. So radiator is interesting.
I had a guy come in. We had old Bill come in with a new prescription for therapy. He practically lived there. And he said for his neuropathy, the doctor ordered erotic therapy for his cervix.
Oh, nice.
I said, I think you mean aquatic therapy for your neck, not your cervix, but for your cervical spine. And we don't have a pool, so we can't give you any erotic therapy for your cervix, Bill. And everyone thinks they have a 3-prong cane too, don't they? But those don't exist other than if you order them on Amazon, but it's 4 prongs. Okay, so what was the middle one after these two? Did you have something in there? Deltoid? Okay. So now, since we have bicep overlapping in both of these, when you study this, you want to focus on what's different because they can't just give you bicep and expect you to know, right? We're not going to erase it, but if you think about it, if they say wrist extensors, supinators, you know you're at 6, but if they're into the shoulder area, it's 5. Bicep lives in both, so it doesn't get to be the determiner. And when you figure out what that word was, let me know, because that was a good word. It was a marker. It was a, yeah, but it was a noun. Okay, so there's that. But that's too much to remember, guys. This is too much to remember. So we're going to tease this out a little more. In the C7, what's the muscles or the myotome tested? So once we come onto the anterior aspect of the arm, we are down the nervous system, aren't we? We're down the spine. Okay. Is there anything for C8 in reflex or muscle tested?
All the deviators, thumb extensors, and the finger flexors.
Okay, now we're into the hand. Did you say finger flexors? And the last one was thumb? Okay, so we know if there's any fingers involved in its cervical spine, we're going to be at C8. We have a little left, especially for those fine motors. C7, we all know it's tricep, but you got to remember that the wrist extension is in there. What nerve goes to the wrist extenders that also is associated with C7? What nerve? What named nerve? If you cut it, you're going to have wrist drop. It's the nerve that does not innervate intrinsics of the hand. It innervates sensory of the hand. What's this nerve? Come on. Nope, that's a little too small and deep. Radial nerve. So I'm just going to, I never put this on the chart, but I'm just going to put radial nerve here, just so you remember that wrist extensors is radial nerve.
Wrist flexors, you mean?
I did put it there, didn't I? It is hold on, this is in the wrong spot. My bad. I meant to put this right here. Thank you for catching that. That is huge. Okay, radial nerve does the wrist extensors. That's C6. You know what? C6, C7. Let's leave radial nerve there, C6, because we've got C6 here. That might help you. Thumb, radial nerve, C6. Wrist extensors. Okay. Are there any, you said there's no muscles tested listed in any of your charts for C4? What do you have? No reflex. Is there a muscle test? What do they test up there? So they do the shrugs, right? I'm going to put traps first. So shrug. Okay, so you still could get confused in all this. Reflexes alone, you only have 3 options. You've got the bicep, the brachioradialis, or the tricep. You know tricep is 7. So the only other answer for upper extremity reflexes is going to be bicep or brachioradialis. Okay? Does bicep get any innervation from C4 in any of your brachial plexus charts, or is it only 5 and 6? Just 5 and 6? Okay. Does brachioradialis get any innervation from C7 at all, or is it just 5 and 6? Just 5 and 6 on there? Okay. All right. So there's nothing that a question can do to separate these 2 muscles, so there has to be something else in the question that's going to separate it for you. Okay? But if you notice, they never test the brachioradialis to confirm it, interestingly. Okay. So let's go to sensory. Let's stick with C6 as our starting point. Because we can easily see that this stuff is north of this, and this is south. Sensory dermatome, what do you have for C6? What does one of your charts say for what sensory area are we getting?
Anterior arm, radial side of the hand, to thumb, and index finger.
Okay, we are not going to write all that. That is too much to write. We need the non-overlapping. Like, what would specifically give you C6 that couldn't be confused? Like, what could you summarize C6 as, and how do you? It's the thumb, right? It's this when you make C6. Okay. So for C6 sensory, how would you write this? Okay, you could do. That's a good one.
That is the sensory for C6.
Okay. Or whatever you could thumb, whatever, however you like, you want to simplify it. They're not going to give you all these out like marginal areas. They're going to be like, it's the thumb. Now you have to differentiate. Oh, is the thumb tingly because of C6, or is it tingly because I have carpal tunnel impingement? Well, it's not your job to differentiate. You're not the therapist. You're not evaluating. But you do need to recognize that there's overlap and there's redundancy. All right, but we're talking about spinal levels. What would be the sensory for C5? That would be simplified, where it's clearly not 6 or 4. What's the C5 dermatome sensory area? We know it's going to be north of C6. So you're talking about the bicep area, the brachium?
It is lateral.
Is it the upper arm, the brachium, or is it the forearm?
It's the entire arm.
Okay. So how about arm? Would that be enough to at least for your study? Like, okay, we have 6, 5. So let's look at 4. How different is 4? Where's 4?
Page 270 gives them good with short little references for sensory.
All right, let's look at 270, see if this helps us a little bit. What do they say for 6?
It says dorsal thumb, proximal
Phalanx.
Yeah.
So when you're sharing, when part of the finger has sensory from one and part has the other, that makes it tricky. So if you stick with the part that is by itself, yeah, thumb, because then we get into this weird sensory in here, but that still works. What does it say for 5?
Lateral side of the antecubital fossa.
Elbow, right here. Elbow crease. How about elbow crease? That helps me. Elbow crease. I think that's how you spell crease. We got the elbow crease. What about C7? Sensory. It's nowhere near the tricep.
Middle finger.
Where is long?
That was on
Middle finger. And then what do we do for C8?
little finger. Ring finger. Ring and lingo.
Ring-a-ling-a-ling. We don't have to be confused and mess up a dermatome question because we get some C5 or C6. We're like, I don't remember. Just simplify it. Simplify it. So when you're looking up here, if you were to simplify, I would focus on deltoid here, wrist extensors here. That's just my thought. That gives you some basic heavy hitters there. Now, isn't it interesting that sensory and myotome don't really line up, do they? They're off. Do you know why your thumb isn't paralyzed and numb by the same nerve? Like C6 is going to make my thumb tingle, but it's not going to make my thumb paralyzed. The redundancy, the overlap is, I believe, your God-given gift to say if something is injured, you at least can either feel it or you can move it. There's overlap so you don't lose function. And the reason there's so much elbow flexors that do all different things is because survival means you can get your hand to your mouth. So there's all different backup systems made. So you can do it in any position with any angle mechanics that you need. It's pretty important. Okay, so there's redundancy. All right, so now we're going to jump, and this is where I say this is very unorthodox. We're going to jump to the central nervous system as if it's the same. It's really not. This is a whole different conversation. But this is where you can get confused on the spinal cord, folks. On your, oh no, C6, can they push a wheelchair? Can't they push a wheelchair? Okay, let's simplify it. C6. What is the functional ability now? Now we're talking spinal cord injury. What's the functional ability of a C6 quad? What do they have? They have this stuff, right? So they can do this. And they can do this. So you keep throwing out the word tenodesis. So if you need to know tenodesis, what's your word association? C6. All right, let's get a good definition of it. What is tenodesis?
Tenodesis is where your finger flexors are tight, and using your wrist extensors, you're able to, I guess, take slack off and close your hand without using your finger flexors.
Okay, that's a good start. Yes, and Stephen, add to that.
I was testing.
Yeah, yep, yes, and add to what he just said about tenodesis. He said the finger flexors are tight, and with wrist extension, you can close in the hand a bit. Add to that. Why are the finger flexors tight?
Why are the finger flexors tight?
Is it by accident? Is it on purpose? Is it by design?
Could it be because of an injury or maybe genetics?
So this is a spinal cord injury. So this means that they've been whacked on the back of the head, neck. They're a spinal cord C6. So tenodesis is a strategy. It's a trick that we teach our patient. So does a C6 person have finger flexion strength? Do they have finger flexion strength if they're a C6? So how are they going to grip anything? They can't. So tenodesis uses tendon length strategy. So the finger flexors, which are a multi-joint muscle, are deliberately not stretched over their full range so that when you extend the wrist actively, which you have, the passive insufficiency of the flexors will draw them in so you can create a weak but functional grip for some things. Now, when we say you don't stretch this, you don't allow contractures of the joints. What do? We splint them in neutral. Fingers go fully straight. But my goodness, if you stretch that person like this, you will be fired. You might as well just walk yourself to the door. You don't stretch them over all their joints. You stretch them down here, you make sure the fingers are working, you have a nice range of motion. But once you come up to here, you have a purposely created passive insufficiency so that the extensors will pull that in and you get a little bit of a grip. That's why they do stuff like this. That's tenodesis. It has nothing to do with inflammation of the tendon. Tenodesis is not a tinnitus or tenosynovitis or tenosis, okay? Tenodesis is a functional hack of using selective, what do they call that? Selective stretching, which means selecting not to stretch. It's called selective stretching also. So you associate tenodesis with C6. Good. What are some other functional considerations about your C6ers? What medical equipment do they need? What will they use for mobility? And what will they use for transfers? What kind of wheelchair?
they use power? Because they don't.
You don't have triceps.
They can use
And C7.
So let's look at what they have. They have bicep.
They can use a regular wheelchair. They might have to have
They would need pegs because since they don't have tricep, they're not pushing the wheels. They're pulling the wheels, right? And to grab those, and they don't have grippers, they have no finger flexors, so they can't grab the rim. They have to grab pegs. So they need wheel pegs, right? What do you call, is that what you call those, Lisa? Wheel pegs?
Yeah.
Let's call them wheel pegs.
Can we just say power chair?
Well, we don't cut to that right away. They would need, they would need power in the community. They're not going to take this wheelchair on their college campus. They're going to need a power chair on the college campus or a power assist. Are they making those anymore? Power assist wheels?
Yes.
Yeah, they do power assist, but it depends. Because it depends on the age of your patient, right?
Yeah.
My patient with it had an electric wheelchair who he just used in his house.
Yeah. All right. So they're going to need wheel pegs because they're pulling, not pushing. What else do they need? How would they transfer bed to chair? They're going to need a sliding board at least, right? Because they can't, yeah. So transfer board. Let's just be simple about it. Let's just be simple about it. So let's compare that to the person who lives on the street above and the street below. C7. What's the functional ability with C7? They can bear weight. So they have tricep. Like we know that. So realistically then they can do transfer board transfers independently. So they could do independent, what we call lateral transfers. They're not up on their feet at all. They're not doing a pivot. They're not doing a squat pivot. They're doing independent lateral transfers. That's huge. And what about equipment? They still don't have finger flexion strength. They have, so those pegs are going to really help them if they can grab those pegs. So they need pegs too, right? They need the sliding board, but they don't, now they can possibly do it alone. Okay, what else? Anything else that separates those two? How would we then separate a C6 from a 7? What do you think could really differentiate the two then? Yeah.
Oh, you mean functionally?
Yeah. They're more likely to be able to drive because they actually can use hand controls for speed. Yes, let's put that here. There's so much more that a C7 can do. Now, where you might get a little bit fuzzy is the 5 versus 6. So let's figure out what 5 and 6 look different. And then when you're actually studying, you're only going to memorize the difference. Okay? Functional ability for a 5. They've got deltoid, they've got shoulder, they got some bicep. They don't even have wrist extension. Can they do tenodesis? No. So what type of hand control would they even use on a joystick for an electric wheelchair? So let's first of all say they're going to need an electric chair. What kind of joystick control would they use if they can't grab a joystick and they don't even have wrist extension? So a goalpost one where they rest their hand on it and they move it with their shoulder, okay? They could do that, but that might even be tricky. So it's going to have to be a goalpost or probably not a sip and puff because they can at least move their shoulder, but they're going to have to learn how to drive with their shoulder muscles, rotators, deltoids. Okay, so you're going to have an adaptive driver, like I'll say goalpost, but and really for many of these because they really can't grab that. Okay, what about functional abilities? Someone who's got, well, I mean, what's the important about C5? I mean, you need at least C5 to be able to feed yourself, right? Even with adaptive utensils you would need.
Elbow flexion.
Yes, they have elbow flexion, which is so critical, but nothing in the hand, so they're going to need everything adaptive. So, yeah, they can do very weak things.
OT has all those things that Velcro on.
Yeah.
You see like 4 years and
Yeah, yeah, you're going to need all that assistance. Yeah. Okay.
We usually need some assistance.
Yeah, we're going to call this I'm just going to put a D, dependent transfers. All right, so you don't have to go too freaked out when you get a question about a spinal level, because you know what lives on 7. And right before the 7th street, you've got the lower elbow flexors. You've got some wrist, but you still don't have anything in the hand there. Okay?
What, C7 be like where they can do their own pressure relief?
Yes, clearly pressure relief. Clearly. They're going to ask about pressure relief. You're right. Clearly. Okay. So you got the shoulder shrug here. You got the deltoid shoulder. You got the wrist extensors. Bicep can go in either one, and then you're already at tricep and fingers. So you do not have to freak out and lose anything on those. You just don't. You know this. Okay?
What be tricky, okay, what I don't get is you can understand all of this and then they throw you off when they be like complete or incomplete, but they have C6, like that's what be, yeah, that be throwing me off. I'm like, now I'm lost all over again because I thought I knew this.
Those throw me off too, and I don't remember the brown and the
Asia.
Yeah, and they throw that in and then they'll.
The good news is Dr. Lisa is going to do a neural review. So there's your questions. So this is a superficial bird's eye view that I'm qualified to give you, and for the folks that might not be in your class the rest of the semester. So for the benefit of those who wanted the miniature version of this neural review. Yeah, this is for a complete. This is the simple stuff.
Okay.
Simple stuff. Okay?
Because I had a patient last rotation, he was a C6 and he walked.
So he's obviously incomplete.
He was incomplete. He had to have been incomplete.
Yeah.
Bro walked.
Yeah.
What?
Or poorly diagnosed.
Did he say what Asia was he?
He's from Europe.
He wasn't in
He was
Asia,
from
he was in
Europe.
America.
Was he A, B, C, D, or E?
He was A for amazing.
That's our story, and we're sticking to it.
Yeah, he wasn't incomplete.
All right. Are we good on this one? We're going to jump to L's. Okay? All right. I'm going to erase this. Did you get a picture of this? Anybody? You guys got all this down? Okay. What do you think is the critical tipping point for the lumbar spine? Where does it all change for the person? Cauda equina? What other consideration? What muscle group do you need in the legs? Quads. Quads. Let's go above and below quads here. And again, we are oversimplifying.
It might be oversimplifying, but it does give you a starting point. You know what I mean?
Keywords.
Like it's the keywords, yeah. So quads, are going to make it a lot easier for them to walk. Okay, but if you try to memorize it, like okay, L2, L3, L4, L5, and you can't. Like you have something in the middle, and everything above that is worse. Everything below that is better.
Mm-hmm.
Right?
That's what I'm saying.
Yep, that's the idea.
I didn't look at my cheat sheet to see if there was anything else I wanted to. Oh, like, so for your C7s who are transferring, they would want, because it's lateral transfers, they would want a drop arm wheelchair. Anything, you need a level surface.
Wait, what?
All of them need a drop off.
When you're doing a lateral transfer,
They need a what?
a drop arm.
Oh, drop arm.
Yeah, drop arm.
What did you say for all of them? 'Cause even if
Oh, yeah.
you're transferring them,
Yeah.
you're gonna want to
Yeah,
drop
for
them.
any
You're
lateral
gonna be, like,
transfer.
dragging them over the top of the.
Yeah.
Pretty
C8
strong.
would still use slide board.
What'd you say?
Well, they still can't stand.
So yeah,
Yeah, so yeah.
the sliding board for C8.
Yep.
Or they could still do.
They
the
still
lateral
can't weight
press.
bear.
They can't weight bear, but if they use the hip head relationship, they can, and they have triceps, they can reach and manage to,
Clear an armrest.
well, you're gonna have the drop arm.
Yeah, that's what I'm saying. That's what she was asking. If
Yeah.
they still need drop arm, for sure.
Yeah, for
Yeah.
sure.
And a transfer board, yeah. If you're not able to bear weight, you're still gonna need that board.
That's what she was.
Okay, let's look at the L's. We'll get the L out of there. Let's start with, where do the quads get their main? Where are quads listed on your myotomes? Where we start? L3. L3 is the magic number. So your reflex is what? What's the reflex at L3?
Knee jerk.
Patellar tendon, right? Patellar tendon. So we know the muscle tested is quads. So we just have to go above and below that. That's the tipping point for gait and transfers. What is the reflex for L4? For L4.
Single leg raise, limited neck flexion pain, weak or absent.
No, reflex.
That's all of it.
That's a reflex?
Flexion is limited.
Under reflex.
Reflex is affected. Interesting. Well, let's go with, okay, we're in the L's. Go to the L's.
That is else.
Oh, I'm sorry. I was looking across. I'm sorry.
It's so weird they do that.
You're so.
Yeah, let's simplify. It's the patellar tendon again.
Mhm.
Yeah, let's do that. That's a weird chart. I don't like that chart.
Yeah, it says weak or absent knee jerk, so.
Yeah, burn that page. Okay. Obviously, the quads are going to have more than one nerve level, right? You knock out one nerve level, you don't want to knock out your quads. So you're going to have at least 2, if not 3 levels that might contribute to the quad. So we know L3 and L4. All right, so for the reflex, it's patellar tendon for 3 and 4. Is there a reflex for 2? Is there a reflex for 5? What is it?
It's also very long.
Cross leg raising pain.
Okay, those are special tests. They're being stupid.
Yeah.
Is there another chart that looks better than that one?
So, you wanna check this one? That one's simpler.
So what do you have for L5?
We have this.
Reflex. Resistive,
This is the
functional
one for
reflex.
test on that,
L4, S1. Nope, there isn't one. It goes to S1. Okay, there is no for L5. You go to S1, you've got your Achilles, okay? So guess what? Just like we only had a few for the uppers, if it asks about a reflex, don't freak out. There's only a few options. Your quad tendon and your Achilles at S1. That's it. That's it. Don't get all freaked out,
Blessings.
okay? So, if you're going to check the integrity of L3 to see how badly somebody's herniated lumbar disc is pinching into L3, you're going to do a quad test. What are you going to test at L4? Yes, the quads still live there, but there's a better test to tease out. The dorsiflexors. Okay, yes, big toe extension is in there too, but now dorsiflexin, that's also got quite a few contributors to it. So they may do the big toe just to be specific and make sure that something isn't cheating for dorsiflexion. But if you're talking about muscle testing, it's going to be dorsiflexion, or let's include big toe extension, because what muscles can cheat for dorsiflexors that might throw off this test, and then you might think L4 is in good shape. What will cheat for dorsiflexors in a muscle test if you don't do it right? toe extensors. Your toe extensors come in, so maybe you're pushing too low on the foot, and the toe extensors are fooling you, and you think there's dorsiflexion. So they say go right to the big toe because nothing can cheat for the big toe. So if that thing goes, it's either the big toe extensor tendon, or it could be L4. So we'll include both of these for that. But you only test quads at L3 because that's the only thing that lives there. But these other things start to live here. Again, we're getting into the foot now. That's kind of important for the function of walking. Okay. L3 is more like Planet Fitness. We pick things up, we put them down. It's just a dumb jock. That's all it does. It just quads. Okay? All right.
Now this has hip flexion, so would you test like for L3?
It is a muscle tested? Okay. Again, because there's other muscles that cross there, I don't know if they would use it as the teasing out, but we know it's going to be up here because it's L2 also probably contributes to hip flexion.
L2, L3.
Yeah. So you could put hip flexion at the bottom of 2 and the top of 3 if you just want to remember where hip flexion lives. Does that make sense? Hip flexion is at the bottom of 2 and top of 3. Quads is here. We know quads lives down here too, but if we're talking about separating it, yeah, we know quads is going to live there too, but these are the big tellers. Okay. What's the sensory for L3? We're going to try to figure out and make quads the equator here, everything below and above. What's the sensory for L3? Where's the dermatome?
Back, upper butt, anterior thigh, and medial lower leg.
That's a lot. I put down medial femoral condyle, like right there, like that doesn't touch any of the other stuff. That's just me. Where was that little tiny short list that you found? What do you have?
267.
That's in the old book.
Medial femoral condyle.
See, that's where I got that from my old book.
Page 73.
What's it say?
Dermatome plastic sites, that one. Middle third of anterior thigh.
Middle third of anterior. Middle third. That's it. Yeah. Anyway, I go with this. Whatever you want to call that. But medial, I put medial condyle.
That's what they said 270 says.
Does it make sense that the dermatome is at the knee? L3 is quads. Just remember, L3 is quads just like C7 is tricep. Like that one, no reason to miss. You just have to figure out right above and right below. All right, let's look at right below for sensory. Now we're going to be coming down. What's sensory for L4? The easiest to the medial malleolus? Can we go with that? That sounds... Medial malleolus for L4. So we got 3 and 4. All right. What's 2? Sensory.
Midway between T12 and L3.
Oh, that's very helpful. What's that say? Intermediate thigh immediately? Yeah, same thing as the old one. I would say it's the groin, is it not?
Yeah.
Let's just say.
Growing.
Oops.
Yeah.
Okay. So when we get below medial malleolus, what's L5 sensory? What is it? Top of foot? But it doesn't include lateral malleolus yet, does it? Just dorsal foot. So what's S1? So lateral malleolus, S1? So you guys can remember this, right? Did you do a dermatome dance?
Yes.
For points?
For what?
For points?
No, they didn't do it for points. They could have done a TikTok thing and they talked about it, but they never did it.
You say that every year.
We got 2, 3, 4, 5, 1. All right, let's L5. Let's. Woohoo! Almost done, guys. Coming in for the landing. L5 muscle. What's the L5 muscle? Is there a muscle that can differentiate? Okay. Okay. And S1? Hamstring is S1? Oh, PFers? PFers and hamstrings? Or PFers?
The big chart says hamstrings, glutes, and plantar flexors.
All right, let's go with the PFers there.
Yeah, I would agree. Like, that's what I would be most worried about, because when you're looking at this, you're kind of going down, and movements don't jump back up to hamstrings. That's really going to mess you up.
Yeah, even though you're going back up. That's a good point. Especially with the so we're taking 6, 7, 8 pages in your book. We're getting it on one page. Okay? And again, you're going to rewrite this stuff out. Add and reduce. So let's switch gears a little bit. There's nothing real particular in the peripheral nerve world that we need to talk about here, other than, even if it's just peripheral, where is foot drop going to be if you have nerve damage? So we would have foot drop occurring here. If someone has herniated disc and L4 is smashed to smithereens, they may walk in with foot drop. What equipment do you give foot drop? AFO. Okay, so let's switch to central nervous system now. And this is where I need Lisa's help, because I know that we have cauda equina and the spinal cord ends at L2, but we also have paraplegia. But do you have L3, L4 paraplegia, or is it just considered peripheral nerve damage if it's cauda equina damage? Help me, Obi-Wan Kenobi.
That is a peripheral nerve thing, because
Yeah.
cauda equina is part of the peripheral nervous
Yeah.
system. Okay, so if they have a peripheral nerve and you're talking about functional ability and they have cauda equina syndrome, what is the best functional ability possibility they could get back? What might they be able to do
Hip flexion.
independently? Well, they will be able to transfer independently, but what would be even more important to that? Because what do you know about the peripheral nervous system? It regenerates, right? So what is a great possibility? No. Yes, knee extension.
Yeah.
And why is knee extension important for walking?
So where does the spinal cord classification system end? Does it end at L2?
It ends at like L1, L2.
Okay. Okay. Phew, at least I got that straight in my head. So if we're talking about central nervous, we're really only talking about the lower T's, the guy that falls out of the tree, breaks his lower thoracic, upper lumbar, where there's that involvement and it's a spinal cord injury. And as you know, if it's a spinal cord, there's not going to be quads unless it's incomplete.
That's incomplete, yeah. So if it was, we can totally damage the cauda equina completely. Like if they had severing at that section, then you're going to have a complete spinal
Okay.
injury.
Okay.
No matter what.
Okay, so let's look at then this more from a peripheral standpoint, what you have, what you don't have. So obviously we need quads to walk, but if you had quads, but you didn't have this, how would you walk? If you had long leg braces, right? Or not, no, if you have quads, you don't need those. If you're an L, you need hip flexors. If you have L2 intact, you can move long leg braces with your hip flexors. It's not the most efficient way to walk. Okay? So that could be long leg braces. We talked about an AFO needed for foot drop if you don't have integrity of L4. Okay? If you don't have plantar flexors, if you have damage at this level, you're obviously not going to have a good push off. You can't toe raise.
Wait, I think we had a practice question like that on the first exam last week. So for L2, you don't need the hip. You could have the knee, ankle, foot orthosis, right? Because you have hip flexion.
Correct.
Okay. That would be for L3. We did. I went over it.
So we would call that a KFO.
Yeah.
Mhm.
Oh, that's L2.
If you have L2 but you don't have quads, you're going to need your knees immobilized. And that's a heavy thing to be pulling with your hip flexors and your lower abs.
So they might use this.
So that's good for practice and feeling upright, but it's not going to be your functional means of ambulation for sure. There's better ways to get around. Anything else you would add to this, Lisa, as far as functional considerations?
Well, you know, independent transfers, they're not gonna have to worry about any of that. They've got full trunk
Mm-hmm.
mobility, which is extremely important.
Mm-hmm.
Okay. Of course, you know, if they need a wheelchair, a manual wheelchair.
Mm-hmm. So when you
independent except for having some issues with walking.
okay. What I suggest you do with this spinal chart, because half of it's empty, when you go and you look at the T's, we know that the T's just go like a striped zebra, right? The most important thing you could study the T's is actually your landmarks. You might get a question, what's at T4? What's at T10? Where is the inferior angle of the scapula? So what I would do, go ahead.
T6.
Yeah, T6 is super important.
Why? Yeah. Why is T6 most important in spinal cord injuries?
Breathing.
No, that's what level is the diaphragm everybody?
Like
About?
what
And what nerve? That was a test question.
See,
The phrenic nerve. That's the peripheral.
Yeah,
What
they're gonna ask like
level?
like
What does anybody remember Christopher Reeves?
the autonomic.
Yeah.
What level was he a spinal cord injury at? No. Two. It was L2.
No, you're not
Or
sure.
C2.
I'm like, it's definitely not L2.
Yeah, C2.
What was really important was
T6
knowing
upper.
that like what happened with the noxious was at
Yeah,
T6.
so
and then
T6, what happened, what is the name of that at T6? Anything with autonomic dysreflexia. Yes.
We did get that question.
so you
That
yeah.
is important in there.
See, 3, 4, and 5 keep the diaphragm alive.
and just
Yeah.
knowing what areas are innervated, because a lot of times they'll ask you like if they're feeling numbness in their big toe, like what nerve is innervated.
We got that. We got that.
Yeah.
Okay. So what I would suggest on the T's is look through your books, anatomy and different things, and write down anything that's important about that landmark, that level. You know, where are your PSISs? Where are your iliac crests? You know, you got T4 is nipple, T10 is umbilicus. You know, just write down anything associated with those levels, and that can just be your one-stop shop. Now you have it on one paper. You're not flipping through all these pages, okay? Same thing with going ahead and finishing off C3 and C2, those things you just talked about. You know, sip and puff wheelchair and breathing, and then the bowel and bladder control with your S's and those things, okay?
Yeah, and how can you tell whether it's a complete? You all will know this.
Yeah.
How can you tell if they have a complete spinal cord injury?
The anal wink.
Yeah. What about the anal wink? If it's complete.
If it's positive.
If they don't have it,
If they don't have an anal wink, they're complete.
See, we did talk about fistulas after all.
Yes, we did.
They like it.
All right, with that, I think we'll take a potty break, and we'll come back in 5 minutes, and we'll